Okay, the next chap I think is Paul Watkins.
He came with a bleeding PR and came with some change in bowel habits, diarrhea. I think GP felt a palpable rectal tumor, which we confirmed on examination. I think you saw him afterwards as well.
Right.
And then we arranged for him to have a scope at Prince Charles.
From what I could remember, it felt like quite a large, bulky tumor just inside the bottom end. And you couldn't get the scope through at all. You managed to get some biopsies.
Yes, I did some biopsies.
Do we have biopsies, Dr.?
Yes. You can see there's two composite fields representative here. There are small groups of malignant glands in amongst this blood and debris, and slightly better preserved area here, which also confirms the presence of an intramucosal carcinoma. So although the material is quite small and fragmented, it is, I think, certainly diagnosable and representative that the patient has got cancer.
Which fits in, I mean, clinically this is cancer, and often the time we felt it. I'd certainly would like to see what the MRI looks like on this one.
Yeah, it is quite a low
It's very
tumor.
low as well, yeah. It's not going anteriorly into the prostate.
No, it's a little fleshy thing and quite low, but as you can see here, there's a plane of cleavage here to the levator, so you're all right there, and there's really nothing much in the way of lymph nodes, so I think we're on a reasonably safe bet there, but it's quite a big tumor.
Yes.
Metastatic deposits in the lungs. They appear pretty clear without any other active lesion also. There was no significant mediastinal or hilar abnormality.
So that's good news in terms of metastatic spread or anything.
Yeah,
So certainly we haven't had a full scope on him. Do we have a baby one? Because we need to just be sure that there's nothing else proximal. What do you think?
Well, I think he's a young, fit guy. He's got a low rectal tumor. You think it's the third query fixed clinically, and it's quite a bulky tumor. A scope couldn't get through. So I think he will benefit from a course of long course chemoradiotherapy over 6 weeks, followed by surgery another 6 weeks later.
Yeah, I mean I agree, because I wouldn't be confident that I could take it out without. If you can shrink it a bit, it would be better. Sorry,
yeah, Harry, probably will need to give him a colostomy before the radiotherapy.
Yeah, absolutely. Yeah.
This also.
Perfectly valid. Yeah. When I'll see him later. You see him with me? We'll do a colostomy first, almost certainly laparoscopically, and then send him across to you to plan some 5 weeks of chemoradiotherapy. 5-6 weeks.
I think we should rescan. We'll rescan. We'll rescan then to make sure things are all right.
We'll let everything settle down. Yeah. Rescan him to make sure there's no advance in terms of any spread in the meanwhile. Also to see how much response we've had from the radiochemotherapy, and if there's been some shrinkage, we'll go for it and try and cut it all out.
Excellent.
Okay. Cheers. We'll see him later today. Mr. Watkins, we meet again.
What do you do?
We met a couple of weeks ago. You obviously know Maria as well. As I said to you when we saw when I saw you last, that we'd get all these biopsies and scans and things organized for you. You've been through all of them. We've had a chance to look through them with our specialist group in our weekly meeting this morning. And I got some good news. It is certainly a tumor. We know we've got that confirmed. However, the good news is that it hasn't spread outside the bowel anywhere. So it's confined to the bowel. There is no spread to the liver or the lungs, which are the common areas where it spreads. So even though it's a cancer, it looks like we've got it at the right time. In your case, it hasn't spread anywhere else. But because of where the tumor is, it's very close to the back passage, right to that bottom end. And it's quite bulky as well. So that's one of the reasons why we do the MRI scan, because it gives us a great deal of detail about the tumor. And in your case, we feel it would be better to try and shrink this down a bit first with some radiation treatment and some chemotherapy. Shrink the tumor down a bit, and then have a go at cutting out the bad bit of the bowel. That we think, on balance, would probably give us the best chance of success. So the operation itself will be done here, but for the radiation treatment, you'll need to go down to Velindre Hospital. Sometimes they'll mix the radiation and chemotherapy together. We've already spoken to our oncologist, the specialist from Velindre. They come to our meeting as well, you see. And in fact, as soon as we finish here, I'll introduce you to him. And he can see you as well and explain to you more about it. But in brief, I can tell you that you'll need to go back and forth to Velindre every day for about 5 weeks to have radiation treatment, which is just a short treatment, but you need to go on a daily basis, 5 days a week. And they'll also give you some treatment in terms of medication to go with it. And then we let everything settle down a bit, re-scan you, see how much the tumor has shrunk or what's happened, and then try and see if we can cut it all out.
You won't need to stay in hospital. It will be done on an outpatient basis, but we'll ask our oncologist and our specialist nurse Helen to go through all of that with you in more detail today.
Right.
Are you having much trouble with your bowels?
Well, I find I've got to go about 3 times a day.
Right.
And a couple of times at night as well.
Okay. So you're getting some disturbed sleep at night, are you?
A little bit, yes.
Okay.
Yes.
When we do the treatment, particularly the radiotherapy part of it, it can aggravate the bowel and irritate it because of the locality. And because of that, to make the process a lot easier for you, what we will discuss with you is doing what we call a defunctioning stoma, a colostomy, while you're undergoing the treatment. This will obviously stop you then having these symptoms made worse during that time. Okay, but we will need to sit down with you and go through that in a lot more detail with a longer counselling session on how you manage and cope with the stoma during that period of time.
Can you tell me if this will be reversible at any time?
Yeah, well, that's difficult to answer at this stage, and I'll be perfectly frank with you. Your tumor is just inside the back passage, okay? Now, if we try to take it out today, it would probably be difficult to join it back up because it's quite low down. But sometimes, depending on how well it shrinks after the radiation and chemotherapy, it might be possible to join things up again, okay? So the plan would be that you would have the colostomy now, okay? We'll send you off to have the radiation chemotherapy, which we'll explain to you. Dr. Mukherjee will see you again.
Yeah.
Then we let everything settle down for a few weeks. We re-scan you, see how well the tumor has responded, how much it has shrunk down, and then we take you to the operation theatre and try and cut the bad bit away. At that time, and it's only then, that we can see whether there is enough bowel below the tumor to be able to join things back up again. Okay, so I'm sorry I can't be very clear about it, be very definite about it at this stage, but it all depends, and there are lots of ifs and buts in terms of between now and then.
We will need to meet up with you again for a longer counselling session, particularly with regards to the stoma formation and the management of a colostomy, which you will have during your treatment. Now, we will supply you with DVDs, and we'll also have written literature for you to take away and to look at, you know, in the comfort of your home. I'll bring you back to clinic to go through that in finer detail with you. We'll also start teaching you how to manage a stoma before the surgery is actually carried out. So it'll give you a bit of a head start on the management issues after the surgery. It'll probably be done through keyhole surgery, okay? And that will enable your recovery to be a lot quicker so that we can get on with the further management then with regards to the radiotherapy and the chemotherapy.
Yeah.
Okay?
Yeah.
Let me pop across next door and see if Dr. Mukherjee or his team are available, because we do a parallel clinic. And if they've got a gap in the clinic, we can start seeing you today and start talking to you more about the radiotherapy and the treatment and stuff in Velindre. Okay? So stay here a second. Let me just nip across the corridor.
Okay, very much.
Cheers.
Thank you, doctor.
So I'll see if they're free. They'll get you out of here.
Thank you.
Obviously,
Cheers.
we'll have contact numbers for our department, so if there are any issues between now and the point of surgery and after surgery, you need to contact us about anything. We're just at the end of the phone.
Good morning, Mr. Watkins. It's Dr. Mukherjee here, and this is Helen O'Neill, our oncology specialist nurse. How are you getting on, sir?
Very good.
Right. Now, I've been asked to see you by Professor Hooray regarding the tumour in your back passage. Now, what has he told you about the tumour and why you're coming to see me?
It's very low in my back passage, and they need to shrink it as such for ready for the operation. And
Right.
The stage is with you now to tell me about the radiotherapy, etc.
Right, okay. We discussed your case in the meeting today, and obviously because of your symptoms, we investigated it. We found that there's a tumour in the lower end of the rectum for which you had the biopsy. Now, we did special scans, and one of which was the MRI scan. And also what Professor Hare felt, and from the MRI scans, the tumour is quite low down, but it's also maybe stuck down a bit, and Professor Hare wasn't sure whether he can take it out confidently without leaving things behind. And we really don't want to get into that situation where things have been left behind. We would rather get the whole thing out. And one way of doing it is to try and shrink it and therefore make the surgery more easy. And that is why we're going to use a combination of treatment with chemotherapy and radiotherapy.
Okay.
Now, the radiotherapy is principally done at Velindre Hospital back in Cardiff. And what it entails, it's just like X-rays, it's just like strong X-rays. So it involves you lying on a bed, and then some strong X-rays are shown at you from various angles. And what it aims to do then is to basically burn the tumour down, and therefore makes the operation a lot more simple.
Okay.
Now, we can't give the whole blast of radiotherapy on one day, and what we do is try and split it over a course of 5 or 6 weeks. So you have your treatment every day, Monday to Friday, for about 5 weeks.
Yeah.
And so it's, I'm afraid, it's a bit of a trek back and forth to Velindre during that piece of
Especially
time.
from where I live.
Yes, but but Helen will have a chat with you regarding, there are transport available, free transport, free cars, which can then take you up to Velindre and back in your own time. So the first part of the treatment actually involves you having a CT scan in Velindre. During the CT scan, we would then use that CT scan to plan the actual treatment. So you go up to Velindre on a day, which we will give you a time for today, and you have the CT scan, and then the radiographers there will call me to mark out where your tumour is. So I will mark that one out, and it goes to a department called the planning department. And looking at how I have marked out the tumour, they will then work out what is the best way to give the radiotherapy. Usually the radiotherapy comes from two sides and from the back. But you don't have to move, you just lie flat, and the machine has a big arm which swings around laterally, to the sides and then to the back, and that is how it delivers. The whole the planning process on the day you go for the CT scan takes the longest, about 30-35 minutes. But the treatment itself is about 5-10 minutes long, so it isn't that bad. It's just a trek back and forth for 5 weeks.
Could you tell me the after effects?
Well, I mean, the other thing we actually give, because the after effects includes the radiotherapy as well as chemotherapy, because we give some chemotherapy alongside it. The chemotherapy are in the form of tablets, which you take at home anyway, so it's not that you have to go to hospital for it. And once again, we will book you into what is called a Cape Cytobine Education Clinic. And once again, Helen will
give you written literature as well.
Give you some information about it, where they teach you actually how to take the tablets, because they're still chemotherapy and they can still have some side effects. But you have the tablets twice a day throughout your whole treatment, including the weekends.
So not tablets.
A lot of tablets, yes, unfortunately. So realistically, you can't very easily separate out the side effects of the chemotherapy and the radiotherapy, because you're having them together. But I have to say, most of the time the treatment is pretty well tolerated, and you're fit and well otherwise, so and you should be fine to go through that course of treatment. As you can imagine, the radiotherapy and the chemotherapy is going into your bowel, and it cannot just treat that bit of the bowel without treating the bowel above and below it. and therefore you are going to have diarrhea because of ulcerations within the bowel. So diarrhea is one of the side effects of the chemoradiotherapy. The other thing that a lot of people do feel is tiredness, and tiredness because of the general effects of the radiotherapy as well as of the chemotherapy. I mean, some people get a bit of urinary discomfort because while we're giving the radiotherapy to the back passage, you know, your waterworks are just in front of it, so that gets zapped a bit. Apart from that, the chemotherapy itself can cause a bit of ulcers in your mouth, and it can sometimes cause a bit of soreness in your hand and in your feet. Sickness isn't usually a problem with this type of chemotherapy, and we do tend to give medications in case you have some sickness. Other than that, you know, as I said, most of the time people do very well on the treatment, and it's usually the first 2 or 3 weeks are okay, and then, you know, week 4 and week 5 there's a bit of a build-up of effect. That's right. So that is the current plan. So it's going to be a prolonged and a drawn-out treatment, and then you need a 4-week break for everything to heal. Apart from your bowel, everything was clear before you started the chemoradiotherapy before this point. So what we will do is at the end of your treatment, after 4 weeks, we're going to do another set of scans to make sure that the tumor is shrunk enough and there's no other problems elsewhere. And that's when I will hand you over to Professor Hooray for treatment. Do you have any questions you want to ask me?
It's just a lot to take in.
This is
really.
This is a lot to take in. I agree, and that's why Helen's there. Helen's will go through it once again with you. Go through some of the side effects again. She will provide you with some literature and other information.
And
but obviously,
contacts
we will obviously be, you know, you'll obviously be seeing me before you start all this again, because you have to sign a consent form. And you will have opportunity to ask more questions at that stage. You can even write down your questions and bring it back to me.
Oh, right. Okay. Very good.
Okay.
Thank you very much.
So take care, Mr. Watkins. I'll see you again.
I'll see you again.
Okay.
Thank you.
You will get soreness of the skin, the area where the radiotherapy field, you know, light is shining at you.
Yeah.
And you will get what they call mucositis, which is soreness inside the mouth.
Right.
And that's partly from the chemotherapy induced, that is, okay? You will get some diarrhea as well, because the chemotherapy can cause that, but also if you've got radiotherapy going through that field, the two together
will cause that.
are going to cause that.
Okay.
Okay?
Yeah.
And what we want you to be honest with us as well regarding the side effects, because some people suffer more than others.
Right, you want me to let you know?
Yes, you will be reviewed weekly in the cancer centre.
Yeah.
Okay, just to see how you're tolerating the treatment itself.
Okay.
And that would be for the chemotherapy and the radiotherapy. But also you're given medications to counteract a lot of these side effects as well, okay?
All right, yeah.
So you will have antidiarrheals, you will have what they call anti-sickness drugs, even though generally that's not a main side effect, but you've got them there should it be a problem.
Should I need them?
And before you do go away today, what I want to make sure is that you've got all the relevant contact numbers. I'll give you mine as well.
Okay.
And that you've got contacts in Palindra.
Right.
And obviously with the specialist nurses in this hospital as well.
Very good.
So that you fit, because quite commonly people will walk out the door and think of questions to ask.
Yeah, yeah.
Okay?
Yeah.
That they haven't asked in here, or they're too scared to ask the doctor.
That's right, yeah.
Okay, so don't mind, I'm here for telephone advice and support.
Okay.
And I'm going to give you written literature, the contact numbers. What I will do when you've left today is I'm going to arrange all the clinic appointments and your treatment start dates, and I'll let you know.
Let me know.
As soon as possible.
Very good.
Is there anything you
Not really,
want
no.
to
I
ask?
think
Do you feel a little bit more sure of what?
Yes, I think I'm up to scratch.
You do?
Yes. Yes.
Okay.
I know his head. Okay. Thank you very much.
Well, what I will do, there's 2 leaflets here. You've got the one, and they are very good. They're point by point, and they're quite easy reading. But you've also got a chemotherapy leaflet there as well, which will break it down one by one, all the side effects that you might experience during it. All right, doesn't mean you're going to, but if it does happen to you, you know what, at least you know what's causing it.
Yeah.
And that you've got the contacts to ask for advice and support.
Okay.
And
Yeah.
my contact number's just at the bottom there.
Very good.
All right.
Okay, thank you very much.
That's okay,
Thank
and
you.
I shall ring you later.
Thank
All
you.
right.
Thank you very much. Thank you.